Really what I'm hoping is that we can have a conversation that will be a win-win for both of us. So what I'd like to do actually is just describe a little bit of what AFTD has been doing to date that we can offer for professionals working in the field, and then also to give you a little bit of a sense of a roadmap for where we anticipate going over the next couple of years, sort of continuing on what Susan had presented in the strategic plan. And then ask for your help and your suggestions and your involvement. And so that's really the outline of what we're going to do together today. And I would be appreciative to know, again, kind of who's in the audience. So how many people are working in a healthcare provider role currently, where you're serving folks with dementia, with FTD in some cases? How many people have used AFTD's resources already? Sue doesn't count. She just did a whole presentation. Tell me what you've used. Just shout them out. Newsletters? Mm-hmm. Great. The awareness cards. Excellent. Okay. Well, good, and I'm glad to hear that. Those are all really good entry points to what we are offering currently and what we want to continue to build on. And so the key really is that it's this current strategic plan that we have, this current phase of our organizational growth, where we're really finally able to truly invest in this area of our mission. So we have a multi-pronged mission. We've been driving a couple of initiatives in education for professionals, but not nearly as much as we have wanted to. So we've tried to take information that we cull from a great group of advisors. Sue Hirsch is one of them. Jill Shapira is another one. We've had the real great good fortune to have some of the really leading experts in clinical care in FTD volunteer their time to help me learn and to help our organization learn, so that we can in turn try to marry that information with everything we learn from families and caregivers, and now increasingly from people diagnosed, and put it into formats that can be useful for people trying to serve folks in the communities where they work. And so to date, the main initiative that we have been able to drive that was started specifically providers, but has morphed over time, is something that we've mentioned a couple times today, which is called Partners in FTD Care. So I put in the back, on one of the chairs as you go back out, when you leave, examples of 3 handouts that come from this initiative. In general, what we've done is the group of advisors, of which Sue is a member, have really helped us to develop a quarterly newsletter that was designed to provide contextual learning, case studies, case-based kind of studies, and then practical information about a number of different issues in care, or specific symptoms or specific challenges that we're aware of. And we targeted those initially for, we thought, the provider audience of people who are working in facilities, because it's such a huge need. And what we learned pretty quickly is that while folks in facilities use them, most of the time they only learn about them because the family brings it in. So we also then know that the families are using this information, which is great, because that's, we're leveraging all the knowledge that we can compile. And so we've increasingly now started to make sure that we're tailoring parts of how we share that for families, so that they know they can take this information to their providers. It's what we always encourage people if they call the helpline, or in other ways that we frame it on the website. But the Partners in FTD Care initiative really was designed originally as one initiative that we could drive on a regular basis, and then try to combine that with the other things that we're offering to get word out. And a lot of times what it looks like is somebody will call the helpline and say, I have trouble finding a facility, or I have trouble finding a doctor that knows anything about this. And we may not yet be able to say, we know a doctor where you live, but we can increasingly say, please take this material to the doctor and let them know that we exist. Raise the awareness that FTD is different, that there are different strategies that are needed in care, and that there are resources that can be helpful. And to the extent that we can be a bit of a clearinghouse, that's part of what we're trying to do. We also are increasing the materials and the strategies that we can use to proactively get word out more. So the Partners in FTD Care is really the initiative that we've been driving for a while. In addition to that, our helpline is not just for families. So if providers are encountering a new family or there's new challenges in care and you think we might have some ideas or things that would help, please call the helpline or email us. It's one of the ways that it's a two-way conversation, right? So we can understand more about what challenges you're encountering. We can offer what resources we have, and then we can also go and try to make sure that we can go back up the line and talk to the experts that we have the privilege of being in contact with and get more information around those topics. So the helpline is often one of the ways that we learn what the needs are in the community, both from the families who are affected and from providers. We have some webinars that we've been doing. Has anybody seen any of the webinars? Great. Because again, this is kind of a hybrid. Like right now, our goal is to get good information out to as many people as we can. So the webinars to date have been kind of targeted for a health provider audience and what we would say kind of a sophisticated family audience, a sophisticated lay audience, where people who are immersed in the disease, who are coping with the disease, again, know that they can hear from experts. We are able to tap experts who are, again, very gracious with their time because they share the goals that we all know are so important. And they'll come on and do a webinar with us to share really the cutting edge of information in research or in genetics or in the different clinical subtypes. So we do now have on the website archived there a growing number of webinars that are usually an hour and a half because we have a presentation and then try to build in time for questions that people can send in during that time. We record them and we can archive them. So I would encourage you to take a look at those as well. It is more of a commitment. You can't really speed through them and you can't, the way they are, you have to kind of manage the technology, but they are recorded and they're available there. What we've done most recently is we do have one on behavioral FTD that was done by a woman in St. Louis. And we have done PPA. We are hoping to do FTD and ALS. We also have a really strong one on the genetics of FTD. And then there's some other ones. The first one we did was on the journey to diagnosis, which was a couple years ago now. But Dr. Beauvais from Mayo Clinic really maps out what's so hard about getting a diagnosis in FTD and some of the differential issues that are encountered. So they're a good resource if you have an opportunity to do an in-service or you have a little bit more time available to kind of look into it yourself or to pull that information. So the webinars are another thing that I would encourage you to become familiar with. And then where we can, we will have staff or increasingly some of our really sophisticated volunteers be available to go out and do some awareness and training in the community. And this is pretty limited right now, quite frankly, because there's a lot of places that calls and say, hey, can you come and do a training? And where we can, we will. But again, what we try to do is really leverage that and be able to say, well, maybe can we make that bigger somehow? Or can we do two things if we're going to travel? And can you help us to do that so that if we come out that we can really make the most of that time? We can do some remote training. So we have had people say, well, can you do a webinar with us? And we can, so if we can schedule it and find the right folks who are available, we're happy to do that as well. But these are all things, like we know the need is huge. We know that moving forward, partnerships are going to be a real key to being able to address some of the needs more. And I'm very happy to say that as part of the plan that we're working on now, we are going to be able to bring on staff a person who will be the manager of our education programs, and that is for professional education. And so the things that we've been carrying to date, we're now going to have a full-time person work with us to expand and to build on. And it's one of the things that I've wanted to do for 10 years. And our board members know we've wanted to do this for 10 years. And part of, if you were here earlier, part of what the wonderful benefactors that we have, they give us a little bit of a runway to start to invest in some staff to do these things that we weren't able to do before. And so we're in the process of doing a search for an education program manager. If you know anybody who wants to work with us in the Philadelphia area, let me know. And the hope is that that person will be in charge of developing the initiatives I've already described and working to expand our reach And the strategy behind it is really threefold. One is we know that we have a lot of volunteers who are really eager to help us because they know how hard it is to find professionals who understand the disease that their family is facing. And so we're going to be developing some targeted materials for professionals and ask our volunteers to start a campaign to go out and blanket their communities with them, because there's a lot of energy there that is ripe and ready to help because they know the need. And so that's one of the near-term objectives, that when we have the staff capacity built up a little bit, we're going to be sending an army of volunteers out into the community so that people, again, know that FTD is not Alzheimer's, that there's information and resources specific to FTD, and that we are a resource to be tapped and contacted and hopefully leveraged to kind of move all the needle forward. The other thing that the manager will be doing when they come on with us is starting to do additional training and preparation so that we can arm more speakers, so that we can have more volunteers who have a better preparation and be available as those folks who might be able to come out to one assisted living facility or a community in their area to be able to present a slide set on, this is basic information about FTD, basic information about how care is different from Alzheimer's care. And again, the idea that there are a lot of people working in this disease. We just need to get them connected with each other and connected with the right folks so that we can support the work that is going on that's so good and expand it and build it more. So those are a couple of the near-term ways that we want to expand and build on what we're able to do to engage you all in the mission that's so near and dear to our hearts. And there will be additional things. We know that the grassroots level is really important. We also know that we've had some opportunities to become engaged with and to be able to do, to partner with folks to do CEU or CME accredited courses when we're a member of that team. So recently I was able to go to the American Society on Aging. I co-presented with folks from the Lewy Body Dementia Association and people who attended that conference, which were all healthcare providers. That's who they are in ASA and across the aging spectrum. We're able to hear about how non-Alzheimer's dementias are different and learn about some of the resources that are there. So we know that professional provider associations and organizations are another way that we can get in front of a larger audience of people who maybe are now aware that there are different types of dementia, but again, don't have the depth of information that they need to improve the care that they want to provide, and to be able to kind of further the learning that they know they're looking for. So the middle level is kind of that professional association. So we've had people speaking on the panels today, speech language pathologists, folks from Sue from the assisted living world, people who are clinical folks, nurse practitioners. We really want to build because many times people will say, well, what's the audience that you're going to target? We need to educate doctors. We need to educate nurses. We need to educate SLPs. We do. We need to educate all of them. We need to support all of these professions to do the best work possible and make sure that we can share what are the best practices. And so we can do a better job of that if we're able to collaborate among various professional associations, get in front of more accredited trainings. We don't have the capacity to do CEUs ourselves at this point in time, but we know that's a really important way of bringing people in. So when we're invited to co-present, and we can do that in the context of a conference that's offering those CEUs, we know we can attract more professionals and get the word out more. And then the third level that we'll be intervening with more over the next 3 years is really at the national level. We're pretty fortunate in that being in Philadelphia, we're pretty close to Washington, D.C., and the conversation around dementia care is really changing in the U.S., where we're finally starting to learn that the U.S. needs to have some system of care to serve people with dementia. And so there are conversations now that at the national level where people are bringing their best thinking together to say, well, dementia care needs to be addressed. We know this is a crisis now. And so our job is to make sure that we're in the room so that FTD needs are included in those national conversations. And this is where our work in educating professionals overlaps a lot with advocacy. And so that's another area where we're really looking to kind of build on some basic groundwork and take advantage of a lot of the foundational relationships that we already have, but have more capacity to build on that. So why am I telling you all this? We need your help. We really do. And we know that it is a partnership between providers and the association to be able to improve the quality of care for people with FTD and their families, and to shorten the time to diagnosis. So a lot of the awareness needs are really the upfront need for people to have information that will shorten the time between when they are experiencing symptoms and when they get referred to a specialist who can make this diagnosis. So in our estimation, that all happens when we get better at getting information out to you, to professionals and to providers. So I'm actually just going to stop there, and I'm ready to take notes, because I would love to hear from you about what is helpful, what you would like to see more of, what you think good ideas are, and how we can kind of work together to engage around what's our mission, but what is our common need in terms of trying to provide better care for folks with FTD. So I'm happy to open up the floor, and I would love to hear your thoughts. Well, we've thought about this. We actually have some colleagues that tried to do a hybrid conference in FTD and PPA for both a family caregiver audience and a professional audience. And we watched really closely to see how that went. And they found it challenging to do that with the sort of the size and the scale and the scope of resources in general in that particular instance. It's something that we talk about, this conference for kind of, again, that sophisticated family audience and professionals who are devoted enough to come without the CEU carrot, which we really appreciate, is a model that works for us so well from the standpoint of reaching the FTD community. But you're right, we know that there's a lot of room to consider how do we reach the professionals. Right now, it would be really hard to say that I thought we could do 2 conferences a year. Could we do something else? Sure. We could think of other models where maybe we do a half day somewhere, or we could partner with folks, or, like we're really open to seeing what would that look like. I don't know about doing a simultaneous track. To date, we haven't had a significant number of professionals attend, so it's hard to gauge what the demand would be. But we're open to all creative thinking.
In Seattle, the Alzheimer's conference does just that. It has a keynote speaker that speaks to everybody, and then professionals go into these rooms and the caregivers come into those rooms.
Right. And I don't know how they do those CEUs either. From the right, so I don't know if the Alzheimer's Association can offer their own CEUs, is what I'm saying, or if they have to partner with somebody. So right now we can't do our own CEUs, and we have in the past actually for this conference offered social work CEUs, which we can tap into, but they really weren't utilized that well. And so it's definitely something we need to think about. Right. Absolutely.
or dementia.
Yeah.
It's clearly so different, or neither, and they don't know what's wrong with it.
Right.
That's why it took us years eventually to actually, honestly, since the beginning of our journey, it's been 3 years since
Three,
I started
3 years.
realizing what's wrong.
3.
Yes.
Yeah. Well, there's some data that says the average, the number that we use, that's probably not really current, but that it takes on average 3.5 years for people to get a diagnosis. And as was mentioned earlier, it takes longer in behavioral FTD than language symptoms and PPA. So sadly, that's not uncommon, and you're right. Um, our mantra, of course, is that everything starts with awareness. So really, all the work that we do has this thread of improving awareness, so that these other doors can be opened. I'm hoping that people heard about the 60 Minutes piece. That's the level of national awareness that's really needed, and then to be sustained and to be built on, because we know that matters. We also have had an opportunity over the last 2 years to have a partnership with folks at Discovery, which did some PSAs. So Martha Madison did a PSA on one of the campaigns. And, we can look at some of the activity in the office when those things run and know when they're running. So a couple weeks ago, some of the helpline staff said, I think they've been running the PSA because a couple people said they saw it on the Cooking Channel or the Food Network. And so, like, it's different than Alzheimer's because we can tell when those kind of awareness things hit. We see a bump in the helpline. Now, not always, and sometimes it's completely speculative, but sometimes people will tell us too, I saw the PSA and that's why I'm calling you. So we know that that kind of awareness is critical, and we're banking on being able to continue to do more of it for just that reason.
So I think if you're trying to get in front and educate providers more, I would encourage you, and I'm speaking now just from a long-term care perspective, but I don't know what you've tried or if you have in the past, speaking at the trade association conferences. So American Healthcare Association, Argenta, Leading Age, those are massive conventions with a huge amount of
Yeah.
long-term care providers. And I think if you were to speak at each one of those to create more awareness about your organization, I think that may make more healthcare providers interested in attending this conference or other things down the road. But that might be your first step, is to go to them instead of inviting them to come to you.
Absolutely, yes. And we have last year, I think we became members of Leading Age for just that reason. So again, that's sort of the thinking behind opportunities at ASA. The American Society on Aging and Leading Age. There's a couple places, and actually, I'd be interested to know from providers in the room, like, are there organizations that you're part of? What are those? So I gather from the long-term care perspective, there are certain ones that are really high percentage shots. Leading Age, I think, is the largest nonprofit group of providers.
So my understanding is the American Healthcare Association actually represents the largest
Okay.
not-for-profit providers, but Leading Age is a little more known for it, just because they're more of the faith-based, more visibly not-for-profit organizations. But again, between the three of them, when you talk about long-term care, I think if you were to speak at all three of them at once, you would pretty much cover almost all of the providers that are a part of the trade association. I think American Healthcare Association has a partnership with a social work organization as well. So
Oh, okay.
I think getting in touch with some of the individuals at each of those could get you in touch with other trade associations that represent different professions, of which I think would benefit from hearing from your team or folks that
Right.
you're connected with as well.
Mm-hmm.
Along the same lines, but also at the state levels. I'm actually from Boston. I'm here with a family member, and that's how I heard about this conference. But I'm also, from hearing about this, I'm going to the Boston conference next month.
Yes.
But like Mass Senior Care that's the trade organization for the Long-Term Association for the senior.
For the state.
Yeah, on
Yeah.
the state level, and every state has their own, on the state level, where all the
Mm-hmm.
And I know, like the Alzheimer's Association, their, their big convention in Massachusetts is this month, Map the Maze. And so, you know, that's where all the long-term care
Right.
associations will be there. And if you had a booth there, you know, they invite people, you know, I don't think it's too late. I think that you could still get into that. But yeah, it's just, I didn't know.
No, yeah, right. I mean, that's the challenge. And when we talk about the volunteers that we have, we're also simultaneously growing our volunteer base, and that's why, so we call them table settings or having booths where we're not necessarily giving a presentation, but where we have a presence. And so we've increased that. The hope, again, is to be able to have more support to be able to do more of those table settings. Because, again, we know that if we're at an Alzheimer's conference and somebody has heard FTD as something in the mix for their family and they see there's an organization, it's an instant connection. So I agree completely. And I think, we see it as a 3-level approach. We need to be in the communities. We need to be at kind of that middle level with providers and at conferences, and we need to be at the national level and figure out, the constantly rejigging of priorities to make the resources to hit all those things.
So many, as a caregiver on the front lines, I have families coming to me, and, I don't have the knowledge, I don't. I have families reaching out to me with knowledge, thank goodness, and submitting articles to me.
Right.
I just got one, and it was interesting today because I heard a doctor's name that I just had a family submit an article to me, Dr. Hodge, that was mentioned today.
Mm-hmm.
And someone had sent an article, a journal article to me about. But, we're only, now I feel like empowered that I know next steps, and I have patients with vertical basal disease, and, I've always had patients with frontal temporal disease, but I can now do more with it. But it is just falling under the Alzheimer's and the dementias and,
Right.
but not with the specifics. I can go be a better nurse.
Right. Thank you.
I think from the other perspective, so I'm a nurse practitioner. I was on the American Association, or the American Psychiatric Association, American Academy of Neurology work group that developed the CMS dementia measures, the quality measures.
Okay.
Right? So what I learned from that was separate from the long-term care, the primary care, so the work group had multiple representatives, and primary care was one of them, and they were adamant. So the American College of Primary Care Physicians and AFTD, American Family Practice something, they were adamant that dementias, specifically generic dementia, Alzheimer's disease, Lewy body dementia, they felt very strongly that those diseases belong to them, not neurology, that they were sort of the front line for dementia care diagnosis, and then tertiary providers like neurology, they would refer the FTDs, the ALS, all of those other cases. So I think that's probably, because that's where the lack of knowledge is.
Mm-hmm.
They want to own that, but they can't really differentiate it. So that, I think, would be a great place to start for you.
Well, and some of the national conversations really are around screening tools. And part of our need is to make sure that screening tools do address looking for younger onset, non-memory kinds of symptoms. So you're absolutely right. And those are organizations, again, that it would be great for us to be able to look into. We need to partner. We don't have physicians on staff, so we need to find out how we get in there. Nurse practitioners we love. I have to tell you, we have loved nurse practitioners for a very long time as really primary educators as well as clinical contacts for families. And so working more with nursing organizations has been also an aim of ours, and figuring out how to do partnerships. There's some wonderful clinical researchers who are nurse practitioners, and being able to kind of piggyback on opportunities to go with them to nursing conferences would be a dream, actually, because those are the kind of audiences we want to be in front of.
Association of Neuroscience Nurses.
Are you a member?
I am.
Let's talk. Thank you. Yeah.
I have two ideas. I'm a neuropsychologist, so one of them is just the International Neuropsych Society that meets once a year. Next year's will be in Denver. They do CEUs. Every single neuropsychologist that wants to be boarded or is boarded usually goes. So it's a bunch of fellows, and it's people that at
Yeah.
least are the ones that are helping make the diagnosis and are part of the clinical care that ends up being able to provide for the families the resources, and also working with the neurologists closely. The other one, and I think you guys are probably already doing it, just given some of the talks, is with the ALS Association,
Mhm.
trying to make a marriage with them. I know at least our ALS clinic, we have an ALS Association member there every week. I know you guys can't do that. but
Yeah, now you're making me feel bad.
I'm saying
But that is a wonderful model. Yeah.
marrying with them, and then also trying to find a way to maybe come once a year to the clinic or something like that to educate our speech pathologists. And
Mhm.
because there's certain amount of clinics around the U.S. I know that there's a lot of them, but Cedars and UCLA, I think, and USC, and so there's a certain number that definitely could be educated more on that, and we try to do that, but our clinic's one of the only ones that has neuropsychology, so there's not very many other clinics of ALS that have the understanding and the expertise for FTD, other than their speech pathologist and the neurologist.
Right.
So I think there's some need there, especially for the ones that don't have neuropsychologists, for FTD Association to be involved.
Yeah, neuropsychology, of course, is such a key part of a diagnostic workup. And we really try to encourage families to recognize that there's an opportunity to ask about how does that inform care. And neuropsychologists working in the clinic level recognize that that's useful information that people can take. Knowing what your MRI scan looks like is helpful in terms of the diagnostic piece, but it doesn't tell you anything about how to manage care, whereas a neuropsych informs.
We make recommendations for behavioral management.
Right. Yeah. Thank you. Other thoughts? I'll go back with this laundry list of ideas. And needing to prioritize becomes the next challenge. Jari.
Sharon, so, listening to the comments that have been made here, I was thinking about, I think that there's sort of at least 3 levels, if not the 5 or 7 levels that we're really looking at. I think we're looking really at, what are the front lines, so getting back to primary care. I know that primary care is very, very hungry for being able to provide appropriate service, to provide appropriate diagnoses, and a lot of times they can't. But the important thing about primary care too is that they're actually the coordinator of care.
Yes.
Once something is sent
Yes.
out for a consultation, it all comes back to primary care.
Right.
They're the ones who need to coordinate all of this. So it's so important for primary care to be educated, however that might happen. The other part is getting to the consultants. So whether it's neuropsychology, neurology, neuroimaging, obviously we don't need to, neuroimaging is a different case. That is also really important. And then I think also just touching on for the later process when people are actually, for individuals who go into some sort of a care system, making sure that those people are also appropriately educated.
Mm-hmm.
And I know in 2013 you did a full day, not you personally, but you were part of the full day presentation at American Psychiatric Association, especially because of the high rate of misdiagnosis of FTD in psychiatry. It's very helpful
Right.
levels to be considered here. And I think it's really important at all of these levels at different points in time.
Well, and that is exactly the challenge. That so much of what we do is really leveraging the resources and the expertise that we can be a catalyst for. So it always feels like we put more on the families who call and ask us for help, but they are tremendously energized. And so at the grassroots level, we know that grassroots awareness is one avenue that we can do. We have an approach that we're working to hone. We can develop materials. We can have a strategy there. Partnerships in the middle are going to be really important. And partnerships at these other, especially physician levels, are going to be really important. And there, it's really, it's relationships. Like, I think prioritizing time and direction comes a lot from relationships and opportunities.
Well,
And-
they termed the G code, I don't know who Bill's here, but there was a G code for, kind of long-term planning visits.
Mhm.
And, because that was one of the big pushbacks from primary care was, we can't do this because we're not getting paid, right? We only have whatever amount of time. Well, so now CMS has an actual
Right.
code that was approved like a year and a half ago, 2 years ago. Half of primary care doesn't even know it's available.
Right.
That's like an 85-minute visit that they
Right.
could be using to do these things, and they are not in the list.
Yeah. Yeah, the bandwidth question is definitely always relevant. And it's also part of why we don't want to say, here's the one audience we're going to go after, because we don't want to miss opportunities that could be really fruitful somewhere else. So part of what we know we're going to try to develop proactive ways of mobilizing our grassroots approaches and then look for additional opportunities in these other areas. So we have wonderful partnerships with colleagues in speech language therapy. We've gone to ASHA. We would never be able to do all the things you need to do to be accredited to do CEUs for speech language therapy, but we can partner with people. And so where we have the relationships, the collegial relationships to do that, there are some wonderful nurse practitioners doing research in Philadelphia, and we've already planted that seed, like, we want to go with you. Please, let's develop a presentation together and put in a proposal. And so it's more a matter of sort of tracking those opportunities and cracking the nut a little bit. Primary care is an interesting one. I don't know anything about how primary care doctors are organized, and it's one of those things that when we have a dedicated staff person to do some of that research, to go out and ask the question of you all, like, all right, well, how do we get into, like, and what would be a smart move to try to get in front of primary care doctors? I don't know that information. And so we need a little bit of lead time to have somebody who can really look into it and advise us to say, this is what would make sense with limited resources, the best way to get the return that you need, at least initially.
Well, I think what's interesting too is I'm a psychiatric nurse practitioner, and a lot of times you get referrals from primary care because somebody has a behavioral problem that has come on suddenly, and you're looking at that going, well, this isn't bipolar, this
Right.
isn't, this, and it's like we need to have you checked out medically, to see if there's some other medical issue going on with you. So I'm going to refer, you need to see a neurologist for this, or you need to be cleared. You have a brain tumor. Is this all, what's happening here? And, so you're getting these people that you normally, obviously if they have a psychiatric issue, you're going to see that in their earlier
Yes.
years, not in,
When they're 50, yeah.
50s normally, develop schizophrenia or, bipolar disorder at that age. And so you normally will, I'll see somebody who has a behavioral change at that later date. And so it's kind of like, we need to rule out medical issues first. So this
Right.
is what, instead of just throwing medications at somebody going, well, I think this is what it is. It's really getting them more checked out, so that they're not just, oh, here's your antidepressant, or here's your mood stabilizer, or here's your
And you're delaying the diagnosis another couple years, right?
and then you've wasted
Yeah.
2 years because the behavior hasn't changed. So, that's the key for me as working in psychiatry, is that, if I get a referral from
Right.
you know, and then, you know, it's like, well, I think we need to have more medical clearance here, like, you know, you need to go to a neurologist, you need to,
Well, we need more of you.
right?
You know, we do. We need more of you who are looking at what's being presented to you and asking the smart questions and recognizing that it may not be a psychiatric disorder, and therefore the next level of evaluation needs to happen. And you're absolutely right. We talk to people every day on the helpline who don't encounter those people until much further down the road. It's absolutely what can help to shorten that time to diagnosis.
That's kind of like the integrated care that she was talking
Yeah.
about with primary care.
Exactly, because
Yeah.
actually primary care should be working them up. I mean, there's a very basic
Yeah.
dementia workup that you do, and then determining, okay, is that psychiatry, is it neurology, so that's kind of, but that goes back to primary care not
Right.
being educated,
Right.
not having the information that they need.
Right. Well, this is really helpful. I have one more pitch I'm going to make to you while I have you captive, and then I'll set you free. And that is that throughout the day, you've heard about the importance of support groups. And we have been extending and growing a network of support group leaders who are doing FTD groups who are affiliated with us. And more of them are coming from the professional world. And I think it's because what we've all encountered, which is that when you meet the families who are facing this disease, you can't help but have a really visceral, personal response to how hard it is. And I think that's driving people to say, well, maybe if support's the answer, maybe I can help and use my skills in that way. So more care managers are sort of saying, I could do this, and I think there may be a need for it. And the affiliation process is one that says we really want to work with people with their skills and with the organizational support that they have to the extent that we're able. The agreement is that we'll provide some additional training and access to training in FTD and materials for folks who are interested in doing this. And it's a volunteer relationship. So support group leaders are AFTD volunteers who are coming on to do a support group facilitator role. So I only mention that because if you encounter anyone who is struggling to find support for a couple of families, we love the model that has a current or a former caregiver or someone who has experience with the disease from the first person perspective and a professional doing groups together. That's the sweetest model and the sweetest approach. And so that's actually what we strive for in all of our groups. But that's a way where a partnership between motivated and interested professionals and the needs of the folks in the FTD community, we can help to connect those. And then the other thing that's a real advantage that people have responded to is that those support group leaders then can have their own support. Because if you've led support groups in any other disease, you know that leading FTD support groups is actually harder. And so to be able to provide a peer network for people who are doing these groups so that there's ways of sharing best practices and sharing support is part of what's built into the model that we have.
So I lead a support group in Phoenix, and my partner is a social worker, but it's where we work, and all we do is dementia. But what I'm interested in, and I don't know if I'm affiliated, but we're on your list.
Okay.
But what I'm interested in is, because you have like telephone group, I'm interested in reaching further than, you know, than
Yep.
people can drive, because Phoenix is huge and there's lots and lots. And in this population, I do this one in Louisville. This population, a lot of the spouses are working.
Right.
Right, so it's really hard for them. So I would like to somehow work with the organization to have like a web-based
Yeah.
support group or something.
Great. So do you know Bridget Moran McCabe already? Okay. So Bridget is the person in our office who spearheads that network. Contact us through the helpline, and I can connect you to have that conversation. We have about 6 telephone support groups that we run directly, again, with volunteer leaders. I lead a Zoom group for people living with FTD. We have 2 of those. One of my colleagues runs that too. And we know that there's a real need for being creative about models that reach other people. So we're very open to those conversations. We've tested a few regional phone groups, And Bridget has done some real thinking about this to see what makes sense and where is it needed to be that creative. And it would be great to have that conversation with you. Yeah. So thank you all. Please stay for the Lifelines wrap-up session. That will be starting promptly at 5 back in the main room. And then we'll have a reception where we can continue these conversations over food and drink. So thank you very much for coming. Appreciate it.